Hi guys, welcome back to Codemaster Coach, your medical coding tutor. We're continuing our studies on the 2019 ICD-10-CM coding guidelines, and we are down to 1B18 talking about the use of signs, symptoms, and unspecified codes. And we did part 1 on yesterday talking about the difference between a sign and symptom and the coding for an outpatient versus an inpatient facility. And I promised you on part 2 that I would answer the question, when can the sign or symptom code be correctly designated the principal diagnoses? So let's continue our studies right there. I want to show you what I have typed up to explain it in detail. Okay. All right, I have here, it says, when can the sign or symptom code be correctly designated the principal diagnoses? And I have number 1, when the diagnostic statement lists the symptom first, followed by 2 or more contrasting comparative conditions, a symptom code may be assigned as the principal diagnoses. However, if the symptom code is integral to each of the conditions listed, no additional code for the symptom is reported, because remember, you're already covering it in those 2 diagnostic, 2 or more contrasting comparative conditions. So you've already captured that symptom code. So long as you code those other 2, you don't need to code the symptom code. Okay? Let's move on. Number 2. When no related condition is identified and the symptom is the reason for the encounter, a code for the sign or symptom is assigned as the principal diagnosis, even though other unrelated diagnoses may be listed. All right, how do I explain that to you? Let's say, for example, a patient's admitted with tachycardia. Okay, we know what that means, right? Their heartbeat is racing. An EKG is done, but it does not provide any conclusive evidence of the type of tachycardia or any underlying cardiac condition. The patient also has insulin-dependent diabetes. The blood sugars are monitored daily during the hospital stay. So the reason for this admission is still what? Tachycardia. So therefore, the unspecified tachycardia is your principal diagnosis, but you'd also code the diabetes because that was also treated during this patient's stay. So again, the principal diagnosis in this case is still what the patient came in for, which is tachycardia. All right, moving along to number 3. A symptom due to 2 conditions rather than as 2 contrasting diagnoses. So your patient in this case has 2 conditions. So in this case, both conditions are coded, and the symptom code is assigned as an additional code only if it meets criteria for reporting of additional diagnoses. So give me an example of that. If a diagnosis is stated as chest pain due to costochondritis. Costochondritis, guys, is like a pain that you have in your chest from overexertion with muscles. It's just your frame of your chest just aches. It just hurts. And this patient also has a possible hiatal hernia. So both your costochondritis and your hiatal hernia, some people pronounce it hiatal hernia, are coded according to the guidelines governing coding for contrasting comparative conditions, but no code is assigned for the chest pain. Why? Because chest pain, the patient will experience chest pain whether they've got costochondritis or hiatal hernia. So I've covered it with number 3. When that symptom is due to 2 conditions, it's covered in those 2 conditions. I don't then use another code for chest pain because it's covered in those 2 conditions that I've already coded. All right, so that's number 3. Number 4, inpatient admission symptom codes. If your patient presents with signs or symptoms that are transient and no definitive diagnosis can be made, then all you can code, guys, is that sign or symptom. All right, B. The patient is referred elsewhere for further study or treatment before a diagnosis is made. If all you have is a sign or symptom, but you're transferring that patient out because it's kind of understood that either one, your facility does not have the equipment to treat whatever's going on with your patient. You see these in these smaller hospitals, and the patient is transferred elsewhere for further studies, or the diagnosis is leading towards something. It hasn't been confirmed, but it's leading towards something that your facility doesn't treat. If all you have is a sign or symptom, then that's all you can code. That's all your principal diagnosis is for that admission. All right, C. A more precise diagnosis cannot be made for any other reason. If all you have is a sign or symptom, all you can code is a sign or symptom. And D. The symptom is treated in an outpatient setting without any additional work required to arrive at a more definitive diagnosis. Again, it boils down to, if all you have is a symptom, a sign or symptom code, then that's all and that's all a physician diagnosed your patient with. That's all you can code. All right, E. Provisional diagnosis of a sign or symptom is made for a patient who fails to return for further investigation or care. And we've seen that. We've seen patients come into facilities one time, and they'll do a lot of lab work, a lot of studies or whatever, but during that admission, it was just a sign or symptom, and the patient didn't return for further studies. So all you have is that provisional diagnosis, which is a sign or symptom to code. And F, a residual late effect is the reason for admission, and the alphabetic index directs the coder to an alternative sequencing. And I've seen that too, where based on the symptom, sign or symptom code, that leads me to a residual. Let me see, how can I explain that? A patient came in for an effect of an automobile accident. And when I'm looking it up in my alphabetic index, it leads me to an entirely different condition that the diagnosis didn't exactly say, but because of the alphabetic index and the way that it directed me, then that's what I'm going to code for that condition. If it leads there, your alphabetic index, that's where you go. Follow your notes. Remember, we covered notes in a previous video as well, how you have to abide by those conventions and those directions of your alphabetic index. Okay, guys, we're continuing. I don't want to make this video too long. In the next video, which is part 3, which will be the final video on signs, symptoms, and unspecified diagnostic coding, we're going to talk about outpatient admission symptom codes. So again, I want you to think about the setting that your patient is in and how to appropriately assign these signs and symptom codes. Ultimately, you're going to see that if that's all you've got to code, that's all your physician diagnosed your patient with. As a coder, that's all we code. However, if that sign or symptom is integral to or a part of a disease process, when we capture that disease process, we've captured that sign or symptom, and you don't then assign an additional code for the sign or symptom if you've covered it in the diagnostic coding. Okay, guys? All right, be on the lookout for part 3. Thanks. I'll see you in the next one.